a survey. Thank you. We will be sharing a survey during this meeting. This survey is confidential but not anonymous to allow us to connect with respondents. Next slide, please. We would also like to note that the views expressed by speakers during this event do not necessarily reflect the official views of SMFM. Next slide. And it is my pleasure to introduce our moderator, Sue Kindig. Sue is the Director of Women's Health Nurse Practitioners Practice and Policy for the National Association of Nurse Practitioners in Women's Health. She's also a Women's Health Integration Specialist for SSM Health Women's Health in St. Louis, Missouri. Sue is a co-author of the Hypertension and Pregnancy Change Package, a key resource for the Action Forum, and we are so happy to have her. So now I will turn the meeting over to Sue.
Thank you. Welcome, everybody. We're so glad to see so many people here today. And I'm just going to put a plug in. Get these dates on your calendar and bring your friends. That's your goal for 2026. I'd like to welcome you. We are so grateful. There's almost 100 people on this call, and they include people with clinical programs, public health, academic researchers. I saw some state Medicaid representatives on here, and our community-based partners. So this is really your call. And your participation is really essential. So we are really looking forward to working with you on this. I want to give you a brief introduction, and for those of you who have been with us before, a brief overview of what we're doing. The purpose of the Action Forum is really here to address hypertension in pregnancy through implementation of evidence-informed strategies, some of which you'll find in the hypertension in pregnancy change package that we talked about. But we are learning there are many evidence-based practices out there, and we are highlighting them because you're doing wonderful work, not only in implementing the programs, but gathering the data and so forth to support them. So during our August call, we introduced the Hypertension in Pregnancy Change Package Learning Collaborative, and we heard from two clinicians who participated in the collaborative cohort. I should also mention that those discussions should be available online. Legacy Health provided an overview of their hypertension intervention that provides blood pressure checks for patients at risk of preeclampsia. And Penn Medicine provided an overview of their Heart Safe Motherhood program, which is a text-based remote blood pressure monitoring program for postpartum patients. Today, we are really excited because we're going to talk about how to support those transitions from postpartum to primary care. And I think that's something that we have heard from a lot of you that we don't have a lot of guidance on. So we are really looking forward to this. Next slide. But when we start the meetings, we always like to get a sense of why are you here today? What is your why? Why do you care about hypertension and pregnancy? And we'd welcome your comments. Either just come off of mute and tell us what your why is, or take a minute and put it into the chat. So Angie, I see you've come off mute.
Yeah, I have. The reason that I am particularly interested in it is because it's a leading cause of maternal mortality in the United States. And unfortunately, the numbers don't appear to be going down enough. They are just continually rising. So that's my why.
Well, and I see that you're with a College of Nursing, and being a nurse practitioner, I think those of us who are in academia we have a real opportunity to drive this change. Diana, hi, I see your hand up, and then Marvella.
Hi, yes. Diana Ramos, California Surgeon General. And my why is also because cardiovascular death is the most common cause of death for all races and ethnicity. And the reality is that 80% of the deaths are preventable. So if we can all work together to identify preventable actions, we are saving lives.
Absolutely. Marvella?
Good morning, everybody. I want to say my why is it's very similar to the other wonderful ladies that have spoken, but I really emphasize on the it's almost like the silent killer. And it's too often that we hear women say, no matter what it was, whether their family is saying it, unfortunately, because they passed away, or they say it because they received trauma, they kept saying after birth, I feel weird. I don't feel right. And they were ignored. And they're like, oh no, you just had a baby. And they're like, no, 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 something doesn't feel right. And I think just hearing those words, we have to start just emphasizing that regardless of having a baby or not, it's different saying I'm tired versus I don't feel right. I feel weird. Something doesn't feel right. And that's my why, to really be able to give moms that education and how to say, yeah, it doesn't feel right. Tell me, verbalize what you're saying so they know, like, I'm seeing spots. Don't say I don't feel right. Say, I'm seeing spots. I'm lightheaded. I've got this banging headache and it's wrapped around my brain. So we can just give them the power that they need so we can stop losing these moms over something that's super preventable.
Thanks, Marvella. Kelly, I'm going to give you the last word and then I'm going to summarize some of the comments because there's some really good stuff coming in.
Yeah, I'll reiterate what everybody else said. And also, I am the perinatal clinical lead for measure development for the Joint Commission and NQF. And so working on trying to create some measures around like AIM and SMFM safety bundles and everything to combat some of this and hopefully help increase some, improve some outcomes in quality care.
I love what I'm seeing in the chat. I had at least two people say my reason for being here is because I want to be here for my grandbabies and my future grandbabies. So we're looking at our own health and so forth. Correct. I'm seeing somebody from the Indiana Department of Health saying that our hospitals are really asking for more information. And as a public health nurse, I love that because that is telling me there is integration between the health departments and the hospitals and most likely the clinics and the community-based organizations. And that's what we're really looking for, right? Clinical community integration. We have PQC staff looking to get information out to their constituents. Megan, I love your why, the fact that this can have lifelong impacts. And that's, as I was listening to you all talk, that's also something that we need to remember. If hopefully we are doing some pre-pregnancy care if we don't catch hypertensive disorders pre-pregnancy, or if somebody has hypertensive disorders during pregnancy and they don't go away usually after the birth of the baby. And even if preeclampsia may be resolved at that point or may be resolved within that first 6 months of pregnancy, that doesn't mean they are not going to be impacted by cardiovascular disease and hypertension throughout their lifespan. So there are a lot of whys, and thank you for sharing those. And we do capture all of this. We capture all of the chats. So we will continue with your fabulous comments. Thank you for informing us about that. Taylor, do you want to go to the next slide, please? Okay. Well, without further ado, so that we can give our speakers maximum time, I'm really, really happy to introduce our speakers and to hear from all of them. So first, we're going to hear from Dr. Zishan. Dr. Zishan is an OBGYN, and she is the Director of Quality Women's Health and Regional Director of Women's Health at Sun River Health in New York. Next, we're going to hear from Dr. Kara Hoppe and Ms. Megan Knutson-Sinase. And I hope I'm saying your names correctly. If I'm not, please correct me when you come on camera. Dr. Hoppe is a maternal-fetal medicine specialist and associate professor at University of Wisconsin Health in Wisconsin. Ms. Knutson-Sinase is a clinical exercise physiologist and research program coordinator for University of Wisconsin-Madison School of Medicine and Public Health. I'll now turn this over to you, Dr. Zishan.
Thank you so much. Good afternoon, everyone. And this is my first time here on this forum, and I am so amazed and touched by everybody sharing their why. And I am really happy to see so much compassion and the reason that you are all sharing and I would love to come back and continue to be a part of this forum. But this is a great opportunity, and some of those things that somebody actually shared really touched me because what I am doing is all, I feel like we all have been through the same journey. So I hope, when I present, so you guys can also connect with me and I can help you, and my presentation can help you in some way improve and make something better for somebody somewhere in another part of the world or in the country. So I'm going to talk about our postpartum to primary care, bridging the gap. But what we call our postpartum care model, it's a 1 year maternal care model, and we call it maternal ongoing care model, MOM. So we can proceed to the next slide. I have no disclosures to share, and while I may use the word woman during the presentation, I want to emphasize that I deeply respect and include people of all genders and gender identities in this discussion. Thank you. Next slide. So a little introduction about Sun River Health. We are federally qualified health centers. We are over 52 health centers across Hudson Valley, New York City, and Long Island, founded in 1975 by 4 African American mothers. Our mission has been to provide high quality health care to every individual, regardless of their ability to pay, race, or background. We offer a wide array of healthcare services at all our sites. Next slide. So Sun River Health provides services to over 4,000 pregnant individuals annually. We support maternal health through comprehensive prenatal and postpartum services. Our main focus is on the underserved communities, which includes mostly low-income zip code areas, and we emphasize a lot on equity and accessibility. We serve a very diverse patient population, serving largely Hispanic, Black, African American, and American Indian and Alaska Native individuals. These groups we know are disproportionately affected by the maternal health disparities. Over the last 24 months, Sun River Health postpartum depression screening rates have been maintained at 87%, which are significantly higher than the national averages, which shows that if the systems and the designs are made around the community needs, then the equitable outcomes are possible. In general, federally qualified health centers deliver nearly 90% of the rural healthcare services. So the existence of the federally qualified health center is essential for access in remote areas. Next slide. So why are we talking about postpartum and primary care? Why does it matter? So we know we have a healthcare crisis in the United States. Over 100 million Americans, nearly one-third of the nation, do not have the access to a usual source of primary care. According to the National Association of Community Health Centers, the number of the health center patients have grown by 6 million since 2015, which is a 24% increase. While we do see that there is a decline in the number of the practicing primary care physicians, which in these, especially the low-income urban neighborhoods and the rural communities. And we know that there are areas where there are no obstetricians or internist coverage at all. According to the American College of OBGYN, to optimize the health of the woman and infants, postpartum care should become an ongoing process rather than a single encounter, with the services and support tailored to each woman's individual. Now, why is it important? Why the shortage of the primary care matters? So if we're going to have the shortage of the primary care provider, this will affect the maternal health care, because when the postpartum patients, they cannot transition into the primary care, their chronic conditions like hypertension, diabetes, cardiac issues, they go unmanaged. So mental health needs, they get also overlooked. And then when we talk about the preventable deaths, they rise. So in 2023, maternal mortality death rates, they decreased significantly for white, non-Hispanic, and Hispanic women. But we know that the maternal mortality rate for the Black women are higher, are significantly higher when compared to the white women. So we still need to do a lot of work in terms of improving the maternal mortality rate, especially about bringing the equity in the healthcare for the women of color. So we see that the postpartum period, it's a medically vulnerable period, yet it is also often neglected. Next slide, please. If we take into consideration medical conditions like hypertensive disorders of pregnancies, cardiomyopathy, mental health crisis, they frequently emerge in the postpartum period. So here today we are going to talk about the hypertensive disorders of the pregnancy. So hypertensive disorders of the pregnancy, they're so strongly associated with the severe maternal complications such as heart attack and stroke, and they are the leading cause of pregnancy-related deaths in the United States. During 2017-2019, the hypertensive disorders of pregnancy prevalence among delivery hospitalization increased from 13.3 to 15.9%. And among the deaths occurring during delivery hospitalization, 31.6 had a diagnosis of hypertensive disorders of pregnancy documented on them. And we know that prevalence of hypertensive disorders of the pregnancy is higher among our patients of color. So the non-Hispanic, Black, and African American individuals are 3 times high risk for developing hypertensive disorders of pregnancy, and non-Hispanic, American Indian, and Alaska Native individuals have twice the risk of developing hypertensive disorders of pregnancy. Next slide. So taking this into consideration at Sunriver Health, we have defined the postpartum care model as a 1-year ongoing model, which the aim is to improve the health of the woman by providing tailored services across the specialties, optimizing the long-term health and reducing the maternal morbidity and mortality. Next slide. Our goal is to create innovation in the postpartum care services, bridge the gap in care between obstetrics and primary care systems, create a multidisciplinary care model, which is a collaboration between the obstetrics, family medicine, internal medicine, behavioral health, and other specialties, increase focus on addressing social factors influencing healthcare, reduce maternal morbidity and mortality, and eventually improve the quality of life for our birthing parents. Next slide. So this is what our 1-year postpartum care model looks like. It is like a grid. It's on an Excel file we have created. We have shared it with all our team members. This model was introduced in 2024. We didn't go through any trials. We didn't go through any studies. We introduced this as we identified that this is what should be the standard, and we introduced it as a policy, as a standard postpartum care model across Sunriver Health. So it is this grid is provided to the person who is our patient representative sitting in the front making to the appointment, the medical assistants who are responsible for rooming in the patients, the nurses, and the clinicians. So everybody gets this same care model. We divided the patients into different groups based on the diagnosis the patients have during the course of the pregnancy, which can be either due to their medical conditions they had prior to the pregnancy or they acquired during the pregnancy, either during labor or immediate postpartum. And based on those, we defined what a 1-year course of care should look like for this individual. And then we also elaborated what should be the interval of those visits. We also gave a kind of a guiding model for the clinicians and listed the content of the visits also during those visits. So it could be a little bit difficult for the folks to read, and if we can zoom in and later on, if you want, I'm sure you will get the slides also. But the content of the visits focuses on almost all the parts of women's health care. We are focusing on depression screening, contraception, recovery, lactation, intimate partner violence, vaccination, including the HPV vaccination, social factors influencing healthcare. And gradually, we proceeded as the postpartum period advances. We also then include other factors like pap smears and creating some healthcare goals for our patients. And then we also then create a time frame. At this point, we're going to refer our patient to the primary care, depending upon the clinical situation or the clinical condition needs. And then so here from here, this is this is like a wholesome picture. We don't want our patients to fall through the crack. So we keep the patient engaged with us also. And we also make sure that the patient is going to the primary care. We bring them back also. We have a discussion with them about their visit with the primary care. So that gives this is the learning process for the patient as well, for them to understand the importance of a primary care or the continuity of the health care basically after having the baby. So as an example, moving on to the next slide, I'll talk about what we have designed for our patients with the hypertensive disorders of the pregnancy. So our patients who have hypertensive disorders of the pregnancy, they come to see us 1 week postpartum. 1 week from the delivery. We do their blood pressure check. We review the signs and symptoms of preeclampsia. Education is also done at the same time regarding the signs and symptoms of preeclampsia. We do the depression screening, recoveries, we do the recovery or the examination of the patient, which may include the wound check if it is applicable, discuss the contraception plan with the patient. We discuss the lactation services. We discuss evaluate and discuss the patient for their social needs. And then we refer our patients to the cardiologist. So we have around 16 health centers where we provide women's health OB services, and we are working with different hospital systems in New York. Some of our hospital systems have existing cardiac OB programs, and the patients do get the appointments upon discharge with the cardiac OB. But we always make sure that we always create a referral. Number one, if the patient missed the referral, so that is created by us. If the patient does have an existing appointment, when we create a referral, because it was created internally in the hospital, unless we do not create a referral, we do not get those notes from the cardiac OB appointment. So this is how then we also then become the part of those visits with the cardiac OB. They know that they are our patients, and then they send the notes to us, and then we can continue to follow our patients the way when they're going to the cardiologist. So then afterwards, at 3 weeks, then the patients will come back to us again. Then we will again do the same blood pressure checks. We will make sure that we will talk to the patient. Did you go to the cardiologist? Okay, what is the plan? Are you going to take the medication? Is there any changes in the dosing? Did they do an echocardiogram? We discuss those changes. Then we talk to the patients about the primary care provider, that we have a primary care provider. Then we have many primary care providers on our side, and we recommend them to follow with one of our primary care providers also, in addition to other things that we already have, I have listed here. So 6 weeks also, then the patient comes back in 6 weeks. I have had patients where if the patient experiences, because secondary to their preeclampsia with severe features, they experience any visual disturbances, we refer them to ophthalmologists. Then the patient will come back at 12 weeks, 4 months, 6 months, 8 months, and 12 months. And the whole goal is that the patient is coming to you, the patient is following up with their cardiologist. Then when they leave the cardiologist office and the cardiologist is saying that my services are no longer needed, that they have an existing primary care who will take over their care. They have a plan of care in place. They have their safety net, and they have their OB that is a part of their care, so that if the patient is missing anything that I fear that they may come back to me 2 years later pregnant again with some comorbidities that may worsen their risk in future pregnancies, I can identify and address them. And then we put some healthcare goals. At the end of the 12 months, we talk to our patients about birth spacing, about identifying the risk factors for their future pregnancies. And that's how we create a 1 year model. And of course, we tell them we are here for them, and they continue to come with us for their regular GYN visits, OBGYN visits for the following years. Next slide, please. So we recently, so this project was launched, this program was launched in 2024. It took us a year to make this roll at the ground level. So it was a lot of work going to like individuals, convincing them, getting them to adopt this model. And so it took us like 1 year to actually make this into effect, where it was practically out of the paper and it was happening in the health centers. And then this year we were able to establish reports where we can see the individual performance, the individual sites' performance now. So this is something recently that I have in my hand that I can actually see the data. So we do not have an existing baseline data to show a comparison of our success or our failure. What I would say that this is what our baseline is right now, and we can only hopefully do better from here. That's what our goal is. So we reviewed the data of 1,046 postpartum individuals, and we saw that these individuals had a postpartum follow-up rate of 90% with their OB within 6 weeks, within 84 days postpartum. So it was 90% compliance. Within 12 months, 34.86% of the postpartum patients, they successfully established care with a primary care provider. Next slide, please. Looking at the demographics, majority of the patients identify as white and Hispanic. Large majority of the patient is young, 20 to 34 years old. Of course, showing us that that's what we see, that's the important area of focus for us now. So we also collected the data on the social factors influencing the healthcare, and we identified that transportation and food was the biggest challenge our patient reported to us. So that is also going to be our guiding our future plans of implementing our some policies and procedures and postpartum care. Next slide. So the lessons we learned. So traditional postpartum care model, most clinicians, they continue to follow the standard 6-week postpartum visit model, which limits the opportunities for this one ongoing care and early interventions. So it is, yes, we can, if you go for the people who are used to doing the quality interventions, you have some early adopters and then there are late adopters. So that's how the curve is always. There are many clinicians that will adopt slow, but we are seeing the success. And given that data now, we know that now we will be able to take the individual performances and also the collective performances on the sites, and this will definitely drive the individuals and the sites to definitely show the improvement from what baseline that we are giving them. Most like many other healthcare organizations, and especially the federally qualified health centers across the country, are facing shortages of the primary care and obstetricians, especially in the rural and the low resource areas. And that continues to be a strain when we want to create a continuity of the maternal health access, and that is a huge impact on the transition to primary care providers. I do get the calls when I say I'm going to be very honest. I have received the calls from my women's health clinicians saying that we're so short of appointment. Do we need to continue doing that 1 year care model? Can we just not give out our appointments to those postpartum patients? So that continues to be a challenge. if we have good access, then I don't think so that anybody would deny there is an importance of continuing engaging our patients. We need to also engage our patients and teach our patients about the importance of continuing the care outside the 6 weeks postpartum also. Especially for those who have not experienced in their previous childbirths. So I have patients who would say that, is this something new? I didn't have that with my other babies. Why are you talking to me about this now? That's why patient engagement and trust building is very important. That's why we continue to bring them back and to continue to talk to them about, like, I know I'm your OB, I can do this for you, but you need a primary care for so and so reason. So that trust building and education is important. Like the trend, like our data showed, younger patient population, the majority of our patients are young patients, especially working in a federally qualified health centers. We see the patients, they come to us when they are pregnant or they have any medical conditions, but they usually do not engage into a routine healthcare checks and routine well checks. So that's where we need to focus more on establishing and focusing models that are aligning our younger population and bringing them into the primary care. Um, Transportation, housing instability, food securities, these are difficult challenges. And I must say that these are the reasons for which childcare, having no childcare is a big barrier. We do provide telehealth services also at our site. We do telehealth, postpartum visits at telehealth visits also. We do new patient visits at telehealth visits, including in primary care across all specialty. Our organization provides that support. But so we're trying to handle those obstacles as much as possible. We have implemented as a policy in our organization that 12 months should be 12 months postpartum should be a policy. It should be a standard, and there should be no question about it if we want to ensure a long-term access to maternal health services. I must say, extending the postpartum Medicaid to 1 year is the biggest strength in getting the support to continue doing this this program for 1 year. So in New York State, we have the Medicaid extended for 1 year postpartum. So that is very important. So I think more states should follow the same. We need more funding, government funding for federal qualified health center to strengthen the infrastructure of the community-based organizations. Medicaid expansion is needed. The more is less, given the crisis that we see in maternal health care. So more postpartum and primary care services can be provided. Medicaid cuts would definitely disproportionately affect our rural and underserved communities. And if it does happen, so this would hinder the preventive health programs. And we fear that we're going to lose a lot of good work that has been done in improving the maternal health across the region. So my broader message here is that our maternal health crisis, for me, it mirrors our primary care crisis. We must put postpartum care as a front line of prevention. And it is the opportunity to engage the patient to create lifelong health goals for them. And by connecting your postpartum individuals into the primary care, we are preventing chronic medical conditions, right? Diabetes, hypertension, cardiac problems. We're improving the quality of life for a mother and for the generations to come. So we need to invest in these programs. So I think every postpartum visit is an opportunity to build trust and to have our patients get an opportunity for a better quality of life that they deserve, and to not to just survive, but to thrive. So thank you so much for your attention.
Thank you so much, Dr. Zishan. That was incredible and so much information. In the interest of time, I'm going to go straight into the University of Wisconsin presentation. So I'm going to ask people if you have additional questions for Dr. Zishan, number one, chat them in, because if we don't get time to get all of the questions, at least we will have them and we can answer them for you offline. And if there is time at the end of the next presentation, we'll go into Q&A for both. So without any more delay, let us go into the Stack My Heart model. And Dr. Hoppy and Miss Knudsen-Sinase, I'll turn this over to you.
Thank you so much. It's a pleasure to be here today. It was a wonderful last talk that we just listened to, and a lot of synergies and goals that we share. But what a wonderful talk, and it really great to hear about your program. Ours is the results of a randomized controlled trial, but also, work we've been working on over the years. So STAC is a Staying Healthy After Childbirth remote monitoring program. My Heart was a prior trial that we conducted with young adults with uncontrolled hypertension, and it stands for My Hypertension Education and Reaching Target. And that was a randomized trial of health coaching to obtain blood pressure control in young adults. So we combined the two of them to see if folks who engaged with 6 weeks of remote patient monitoring that still had uncontrolled hypertension would engage with 12 months of health coaching, and we're going to talk to you more about that. So Megan was the lead research coordinator, but also very skilled in health coaching and exercise physiology. So she's really key, and you'll hear about her from her in a minute. Kristen is our lead nurse on the STAC program. So sorry if the text is coming in a little bit small for people, but background and motivation for this particular study, I just talked a little bit about. We developed our remote monitoring program that is similar to the PEN program that you've heard about in the past with texting postpartum for blood pressures. We use a vendor and a full remote monitoring app that's connected to our EMR. We studied it, back in early 2016, 17, and then implemented our program in 2019. We enroll people from the hospital postpartum, give them education on self-measured blood pressures, and then connectivity for submission of daily blood pressures through 6 weeks. We have treatment algorithms that are nurse delegation protocols for monitoring and treating hypertension from people's homes. Our readmission rates are significantly reduced, and we maintain those typically around 1%. And our hypertension population out of our 5,000 births is about 1,800 per year. And everybody goes home with this program standard of care. So it allows for us to have kind of extended surveillance at this time. We found, transitions of care outside of the 6 weeks postpartum's period was super important, but devastatingly, even though we were referring patients, many did not attend any, follow-up after those 6 weeks. So we found about 30% of people with preeclampsia severe features, 25% with preeclampsia without severe features and gestational hypertension still required medications or treatment of their hypertension at 6 weeks. But when we would refer them for follow-up, many of them, 30% or less, even engaged with a follow-up appointment. And the slide on the right is just data to show, the types of hypertension which we've published and the amount of patients that still have hypertension or don't recover their systolic and diastolic to the baseline values before pregnancy by those 6 weeks postpartum. So acknowledging people need adequate transition, and the lack of successful transition was really a motivation for this project. Additionally, we know that having a hypertension disorder of pregnancy increases cardiovascular disease risk long-term. We followed a lot of work and advocacy by the Preeclampsia Foundation, who recommends birthing patients have blood pressure checks. In that, first year postpartum, they have a really great patient-facing document to help navigate that period with a 6-month recommended follow-up, as well as 12 months follow-up laboratory assessments, et cetera, to help kind of risk stratify people's cardiovascular disease, but also reduce that long-term risk. Already mentioned, but when our STAC patients were assessed, just 30% of our referred patients actually scheduled an appointment and less of them attended those appointments. And so we wanted to do better. I should also mention we don't have Medicaid expansion coverage in Wisconsin. And so most patients' care ends at 6 weeks as well. So the aims for this project were to improve postpartum care attendance for a 12-month hypertension follow-up appointment among our STAC patients who had chronic or persistent hypertension at 6 weeks postpartum, while gaining knowledge about what would blood pressure control look like at 12 months between our two study groups, and then also the ability to influence lifestyle modification behaviors and health outcomes relating to a lot of the life's essential 8, but nutrition and physical activity, as well as CVD prevention. Our study population was recruited from a Midwest academic/community center. It's Unity Point Health Meriter Hospital. These are all the births occurred. The demographics match the population of Madison, but generally the U.S. population as well. We had around 1,800 SAC participants that were cared for between February 2023 and April of 2024, our study period. And of those, 771 were identified by our lead STAC nurse as potentially eligible and called. And of those folks, 140 were interested, eligible, and enrolled. And then regarding our trial schema, pretty soon on the next slide, I'm going to be having Megan take over. But our intervention and standard of care arms included 70 on each side, 1-to-1. On the intervention, folks would complete our STAC program, which was involved having a blood pressure monitor. But these folks in our intervention arm would also get a weight scale. Our referral was placed for transition of care and to a primary. We gave them educational handouts for recommendations of follow-up and primary care at 12 months, as well as labs. And then coaching calls were done with our health coach every 2 weeks between 2 to 6 months postpartum. And then we had a maintenance call phase that was monthly from 6 to 12 months postpartum. And then on our standard care side, folks all completed STAC. They did get a blood pressure monitor and got to keep that from the program. These folks did not get a scale at that time. They had a referral placed again for transition